So the main renal replacement therapy is represented by hemodialysis, with the arteriovascular fistula designated by guidelines as the best available vascular access. Longevity in dialysis is directly proportional to the quality of dialysis, which depends on reliability and integrity to access the vascular system, with the ultimate goal to have a functional, durable, and with low complication rate vascular access. But the downstream is represented by the complications, with the thrombosis being the leading cause. And in most of cases, there is an underlying stenosis. Also, some systemic factors can increase the risk of access thrombosis. As by the formed thrombus, we can distinguish two components: a soft friable clot in the venous outflow, which can be easily disintegrated, and a firm fibrin plug near the anastomosis. As the international guidelines, they suggest an individualized approach treating these complications based on the operator's best clinical judgment and local expertise. But they highlight the fact that these procedures should be carried out as early as possible. The purpose of our study was to assess the outcomes of percutaneous mechanical thrombectomy in AV access thrombosis. Primary outcome consisted in the evaluation of the primary assisted, and secondary patency, and the secondary outcomes in the evaluation of thrombus length removal, procedure time, and other important secondary outcomes. All complications were documented and classified according to the last version of the CIRSE classification system. So we treated 16 patients, equally distributed between male and female. The EGA nephropathy and hypertension plus diabetes were responsible for half of the etiology for the end-stage renal disease. 15 out of the 16 access treated were native fistula. And as you can see from the Kaplan-Meier, the patency rates progressively decrease over time, with a drop in the patency rate at a 24 months follow-up. The mean length of the thrombosis treated was about 11 centimeter, and the underlying stenosis was presented in 81% of the cases, always treated with high-pressure balloon angioplasty plus drug-coated balloon. Anatomic, clinical, hemodynamic, and procedural success were very high, but when we redefine clinical and functional success according to the standard reported by the nephrologist, they dropped to almost 70%. And important, we had a previous intervention rate of 1.7 for AV access. So when we look at our outcomes, we see that they are in line with the suggested threshold from the SIR and other studies published in literature. But when we look to the secondary patency, at 12 months we had a lower patency rate as compared to the threshold or the other studies. Our procedure time, length of thrombosis, technical and clinical success were in line with different studies previously published. And when we see to the literature, this meta-analysis published in 2013, which looked to the outcomes over 500 procedures, the authors found comparable results between endovascular techniques and surgery, and they outlined the fact that long-term data was lacking in both of the groups. In this more recent meta-analysis, which looked to the outcomes of more than 1,000 patients, the authors reported that endovascular procedure were correlated with, had a significantly lower 1- and 2-year primary patency and a significantly higher technical failure rate. But as regarding for the secondary patency, there were no significant differences between both groups. And as also outlined by the author in this meta-analysis, 8 out of the 10 studies which were included were conducted before the 2000. In this nationwide observational cohort study, which was conducted in Sweden, the author looked at the outcomes from more than 900 procedures, and they found that endovascular procedures were associated with higher short and long-term benefit in the follow-up compared to the surgery, although even if the results were not statistically significant. And the follow-up in this case, there was up to 5 years. When comparing different devices which are presented, which have been used, the primary patency and cumulative functional patency were higher with the rheolytic and rotational thrombectomy as compared to aspiration thrombectomy. And when we look to the data from the comparing pharmacologic thrombolysis and mechanical thrombectomy, in this meta-analysis of more than 1,000 patients, the author stated that both techniques are similarly effective and safe. So, jumping to the conclusion, percutaneous mechanical thrombectomy can be used as a primary salvage intervention for thrombosed AV access with high technical and clinical efficacy. This technique is efficacious also with extensive thrombosis. Additional research with long-term follow-up data, it's necessary to comprehensively evaluate patency rates and the heterogeneity of the data present in the literature suggests to conduct randomized control trials to draw evidence-based conclusions. Thank you.